Should be able to already.
Okay, right. Okay, thank you so much for that kind introduction. It's a pleasure to be here with you all this evening. As Kadar mentioned, my name is Christina Roup, and I am an associate professor in the Department of Speech and Hearing Science. I've been at Ohio State. This is going to be my 18th year, so I feel like this is home. But I did start my career in the Department of Veterans Affairs as both a clinical audiologist and a research audiologist working with veterans, which was a true pleasure. So that sort of started my interest in individuals who have age-related hearing loss. That is where I started with my research career, but over time that has evolved into an interest in looking at the impact of traumatic brain injury on auditory function, what we see, and we'll get into this as we go through my presentation, but we're seeing, particularly with veterans, with children, with adults, that there are these long-term auditory consequences that create problems hearing, understanding, communicating. And so I'm going to give you a bit of an overview of the auditory system, how we think about hearing, and then share some clinical data with you and some research data with you. I will try and move through my slides so that there's plenty of time for questions, but I would also say, ask me questions as I go along. I'm happy to pause and talk about things as we move through them. So I'm going to go ahead and share my screen as soon as Kadar will enable that for me. Okay, here we go. Okay, so hopefully you can see my title screen. Yes. Okay, great. Thanks. I always, that visual feedback with Zoom is very helpful. So the title of my talk this evening is Hearing Difficulties Associated with Traumatic Brain Injury. And I'm the PI of Speech Recognition and Aging Laboratory. And as I said, my first love is aging. My second love is traumatic brain injury. Okay, this is my outline for tonight's talk. I've chunked it into 4 different sections, and my plan is to work through those and pause as I go. So if you have questions, again, feel free to jump in. Not knowing how familiar you are with the ear and how hearing is tested, I thought I'd start there to give you just a brief overview of the auditory system, then move into how traumatic brain injury can impact the ear and hearing. So that's going to be our second topic. The third topic is going to be that clinical data that I mentioned. So I'm going to share with you a published case study from our department and from some research that I've done in my lab. And then at the end, I'm happy to share with you some of the current research that I'm working on, where we are recruiting and measuring auditory processing in adults who have a history of traumatic brain injury. So that's what we're going to talk about this evening. So here we have an image of the ear and the auditory system. This is chunked into different areas of the ear. We have what you can see on the outside, which is the auricle or the pinna. It's what we can grab onto. It's where we hang our earrings, where we put our eyeglasses, where we hang our hearing aids, if you have hearing aids. But that is where we collect sound, and that's transmitted or conducted down the ear canal and stimulates the tympanic membrane. The tympanic membrane is this junction to the middle ear space where we have these 3 little bones. One of those bones is the smallest bone in the human body. There's a little trivia for you. It was actually a Jeopardy question a long time ago. but that's an air-filled space and is attached to the eustachian tube, and that connects your ear to your respiratory system. So, when you're flying in an airplane and your ear gets plugged, you have to get that eustachian tube open to equalize that pressure. And then that transmits the sound or speech into the inner ear. And that is where sound is transduced and turned into neural energy and sent along the auditory nerve. So that's a brief primer of the peripheral auditory system. What I wanted to show in this next slide is, I think, a more important part of the auditory system is the fact that we have two ears, one on each side of the head, and that both of them are connected to the brain, so that you can have a perfectly normal outer, middle, inner ear, but you can have injury to the brain that impacts your processing of sound and of speech and can impact your communication. So there's this connection between your ear and the central nervous system or the brain. The other thing that I think is important to take into consideration in this picture, or think about in this picture, is we have two ears. And those two ears work together very beautifully by helping us determine where sounds are coming from, to localize. Two ears working together helps us hear better in noisy situations. And so there's some real advantages to listening with both ears. And again, attached to the brain, where the brain processes that information. So that's the auditory system. Any questions about the ear? It's a really brief overview of the ear and how we hear.
If you have questions, you can absolutely put them in the chat. You can also just unmute and ask the question out loud.
Okay. So when we think about traumatic brain injury, how might that impact the ear, and how might that impact your ability to hear and communicate or process sound and speech? Well, one way is that it can actually, an injury to the temporal bone can cause hearing loss, and I'll show you some examples of that. Some other common auditory symptoms include tinnitus, or ringing in the ears, and sound sensitivity. Those tend to go hand in hand. They can co-occur or they can occur in isolation. Some people experience dizziness or imbalance after a traumatic brain injury. And my area of research really deals in this last square, talking about hearing difficulty. This idea that you don't have hearing loss per se, but you have that there are individuals who have difficulty communicating, understanding speech, especially in really challenging environments like restaurants or parties or a classroom, where there's multiple distractions, lots of people talking, all that noise. And so this is something that happens in the brain. It's difficulty processing that information. And sometimes we refer to that as hidden hearing loss. So it's not a true hearing loss that we would measure clinically with a pure tone audiogram, which is a way in which we present tones. You might have done this if you've had your hearing tested, or if you had your hearing screened in the school. You might have someone put headphones on you and they play a tone and you have to raise your hand. Yes, I heard that. That's a hearing test using tones. And that's how we identify hearing loss, the very first box over here. But the hearing difficulties, again, that's my area of interest. And so we use tests that really stress the auditory system. So we present speech and we present noise, and we ask people to respond to that speech signal, even when there's lots of noise in the background. So I'm going to go through these individually to give you a little bit of background on a little bit more expansion on these topics. But I know next week, my colleague, Dr. Gail Whitelaw, is going to be talking about these topics as well, and really delving into, if you experience some of these, how we can help you as audiologists and as clinicians. So a traumatic brain injury can occur really anywhere in the skull, but if it happens to be in the temporal bone, that's the bone on the side of the head. That is actually the hardest bone in the human body, and it really serves to protect our ear really beautifully. But that bone can be fractured with a head injury. And as you can see in these images, this is an image of the ear showing the outer ear, the middle ear with the little bones, and then the snail-shaped organ, that's our inner ear, and then the temporal bone surrounding it. And you can see I've circled a fracture of that temporal bone. So the fracture of the temporal bone can also impact the structures of the middle ear. And in this case, this is an example of a longitudinal temporal bone fracture, and that causes injury to the middle ear and can result in measurable hearing loss. And so that's when sound softer or muffled and you have a hard time hearing. This is something that we can address clinically very straightforwardly. And so that could be through medical intervention with a physician or audiologic intervention with amplification. Very straightforward to address this. The second example is an example of a transverse fracture. So this is in a different area of the temporal bone, and you can see it is impacting the snail shape organ, which we call the cochlea, but also these yellow fibers, which are actually the auditory nerve, one of the cranial nerves. And if that fracture impacts these structures or these organs, that can result in a very severe hearing loss. And that is difficult to treat medically, but can be treated audiologically through hearing rehabilitation. So these are two examples of if there is a fracture of the temporal bone that can result in measurable hearing loss. Any questions? I'm going to try and not to speed through this. I'm trying. Okay. So that's hearing loss, but what about other symptoms that are common to head injury? Tinnitus is one that is very common. Tinnitus is defined as a sensation of sound. Oh, someone has a question? No? Okay. Sensation of sound that you hear in your ears, but there's no external sound present. So sometimes pronounced tinnitus, sometimes tinnitus. It's up to where you live really on what pronunciation that either one is correct. But sometimes it can sound like buzzing, like chirping of crickets. Some people describe a whirring sensation like a fan. Probably one of the more common descriptions of tinnitus is hissing or whistling like a tea kettle. It's really an individual perception and experience. It's individual to everybody. What I will say is that everybody experiences tinnitus to a certain extent. It's just when it becomes constant. Most of the time, tinnitus is something that happens very periodically for a very short amount of time. But one of the impacts of traumatic brain injury is that tinnitus can become constant. And when it becomes constant, it can become very bothersome. And so some of the causes include noise exposure, sound exposure. As we age, hearing loss is common as we age, as is tinnitus, but you can see head injury is one of the more common causes of tinnitus. In addition, there's certain medications that can cause or exacerbate a person's tinnitus. So if I were working with a patient who had tinnitus, that's one of the questions I would ask: what medications are you taking? Because that can be a trigger. And surprisingly, if you have a buildup of earwax, this one always sort of makes me pause and go, I wonder why that happens. But it's common to happen if you have a buildup of earwax. By the way, earwax is completely natural. It's normal. Your ears need earwax. It maintains the health of the ear canal. So earwax is not a bad thing. too much of it can be problematic, but it's like there's a Goldilocks effect, right? Too little is problematic, too much is problematic. We want just the right amount. I see something in the chat. Somebody has a question? No. Okay. I'll keep going.
Karen, did you have a question? She did.
Yeah, sorry, I was dancing around this computer screen. Question I have regarding the earwax question. If there's a theory that some of the tinnitus might be a result of inflammation and that the earwax is a residual production of some of that inflammation. Have you heard anything like that?
I haven't. That's an interesting thing. Earwax is not a result of inflammation.
No, but the change that happens in the surface of
I see. Yeah,
Yeah.
no, I can see that makes some logical sense. I'm going to tell you that tinnitus is not my area of expertise. Next week, when you have Dr. Gail Whitelaw, she is the expert. And so what you just shared, I think makes some logical sense, that pressure on the ear canal, that inflammation from a buildup of wax can trigger the ringing. Is that what you're saying?
It's more at the neurochemical level.
Oh, yeah. See, you know more than I do about that.
They had a tinnitus research thing like 2 weeks ago.
Oh, cool.
Online, so I learned a lot there.
Very good. Well, I apologize for not being able to answer that better than that. But hold that question for Dr. Whitelaw. Okay. Mm-hmm. Okay, so tinnitus does have some negative consequences, especially if it is constant and persistent. It can cause sleep disturbances. You know, when we go to sleep at night, we go into the darkness in a quiet environment, and that's usually when people hear their tinnitus the loudest. So it can keep you from falling asleep and staying asleep. It can result in an inability to concentrate. It can create the cycle of stress and anxiety and depression. But the good thing is that there are absolutely effective treatments that can help relieve those consequences of tinnitus. So there are, and again, this is something that Dr. Whitelaw will expand upon, but sound therapy, you know, one of the best pieces of advice for individuals who experience this is don't ever be in a completely silent environment. Just a little low-level noise can make all the difference. Hearing aids work beautifully to alleviate the consequences of tinnitus. And then there's always counseling, meditation, there's counseling programs that work people through habituation techniques to habituate to the tinnitus. It's breaking that cycle that's keeping you awake, that's making you stressed and anxious. I know this presentation was sent out to you yesterday, and I included a link to a news article that talks about preventing and relieving tinnitus, which I thought would be a good source for you, should you want it. Okay.
Christina, can I jump in real quick?
Yes.
So there was a question that was posed. So there's
Thank you.
Parts to this. The first one, I'm curious to know if this would be an answer you can give. So the negative consequences are similar to what you might see in PTSD.
Yeah.
From an audiology standpoint, is there a differentiation that you make between the two?
You know, as an audiologist, it's outside our scope of practice to treat PTSD. I don't think that's the answer you're looking for, but we do testing in the audiology clinic to very specifically define the tinnitus that a patient has and to characterize that tinnitus. Now, certainly, I think there is a connection between tinnitus and PTSD. And as an audiologist, I would want to work with neuropsychologist who can deal with the PTSD aspects. And if we work in together and in our own domains, but working together, we can treat both. Does that answer the question?
I think it may. And so then the other part is, can you go a little bit more in depth on sound therapy?
Sure. So sound therapy is using ear level devices. It doesn't even have to be an ear level device. The most basic definition of sound therapy is having a bedside masker or having a fan on in your room when you're sleeping. They sell bedside maskers that generate white noise, or it sounds like static. I used to tell my patients, turn your bedside radio in between a station. So not a station, but static. It's just white noise. That's a very low level sound therapy. What you're doing is masking the tinnitus so that you can't hear the tinnitus. You hear this other noise that isn't bothersome. Now, there are ear level sound therapy devices that give you the same idea, but in your ear. So devices that look sort of like a hearing aid, but are not a hearing aid, that you can adjust the volume, you can wear all day. There are some of these sound therapy devices that are way more sophisticated than that, where they play different types of sounds, not just noise. But the idea is, so you're not concentrating on the tinnitus, and it serves to mask the tinnitus, to sort of break that cycle. And again, this is an area that I think Dr. Whitelaw can really, she does this type of treatment every week. She's a tinnitus specialist, so she'll be able to expand upon that.
Awesome, thank you.
And Karen, you have some new tech you wanted to share.
I think we'll wait till the end.
Okay.
Yeah, if we could do that at the end, then we can,
Yeah.
that'll be
Sure.
a chunk out.
Okay, so that's tinnitus. The main message I want to get across to you is that this is something that is absolutely treatable, that we can alleviate this. We can work with you to alleviate bothersome tinnitus. One of the most tragic things that happens that I hear about is that patients go to physicians or what professional they're going to, and that professional will say, there's nothing we can do, you just need to learn to live with it. And that's absolutely not true. And so I think you may have experienced this, and I certainly have. It's finding that right professional to help you with a particular issue. Hand in hand with tinnitus is something called sound sensitivity or hyperacusis. So again, a common symptom in the auditory domain post brain injury is having an abnormal sensitivity to sounds, so that even moderate but loud sounds or even moderate sounds can cause discomfort or pain. So the idea behind this, I found this great example of how to think about it, is that the brain is turning up the volume of the sound that you're hearing, creating this discomfort. And so the sound really is louder to the individual who experiences this. And again, the causes, the negative consequences in the treatment are essentially the same as with tinnitus. So you get sleep disruption, inability to concentrate, again, stress, anxiety, depression. But again, how we treat hyperacusis is very similar to how we treat tinnitus. To me, the idea that taking hearing aids, which amplify sound, to put that on someone who has sound sensitivity, this took me a while to figure out as a clinician and as a researcher. But when I read this quote about the brain's auditory system of turning up the volume, what the hearing aid is doing is modulating that. It's not allowing the brain to do that because the hearing aid is doing it itself. Hopefully that makes sense. That's the way I've wrapped my head around that. Excuse me. Fibromyalgia also increases some sounds as bothersome. There's those negative consequences and downstream consequences to things like fibromyalgia that we don't even think about, right? But here, perhaps that is an area that we can help you with in audiology with some of these treatment techniques. That's interesting. I hadn't heard that. I didn't know that. Dizziness and imbalance is another common symptom post head injury. So, the ear and the auditory system is one sensory system that helps us maintain our balance. So we use our vision, our eyesight, we use our proprioception. So our ability to tell if we're standing, that we're standing on a flat surface or we're on a slant, that's proprioception. So our muscles and joints tell us about the surface we're standing on, but the vestibular system, or the part of the inner ear, that helps us maintain our balance, and it tells us where our body is in space. So it can tell us that we're sitting down or if we're lying down. And then we know the difference of lying down and standing up. The vestibular system tells us if we're accelerating in a car, how you can feel that acceleration. That's a change in the vestibular system, sending that sensory information to the brain. But that part of the ear can be affected by a head injury, causing these lingering sensations of dizziness and imbalance. And so head injury is one of the more common causes of this symptom. So feeling dizzy, feeling unsteady as you're walking, that's actually different from vertigo. You might have heard of the term vertigo. Vertigo is very specific to if you're sitting or laying down, having the sensation that the room is spinning around you. That is very different from dizziness or unsteadiness. But this can also make you feel bad, make you nauseous, can result in a lack of coordination. So it can be very debilitating. But again, here is another area in which we can absolutely help patients who experience this. So there's balance and vestibular rehabilitation, often either with an audiologist or with a physical therapist. There's vision therapy that can assist with this, certain medications, diet and lifestyle changes. And really, I think surgery is something that is the last resort when it comes to addressing vertigo or dizziness, but definitely ways in which we can manage that symptom. Okay. All right. So this brings us to the last category, and this is actually my area of interest. How would diet help? I'll go back. Thanks for asking that. So one of the ways in which diet can help is if you reduce your sodium intake. So if you've heard that sodium causes you to retain fluid in your body, and fluid is present in your inner ear, including your vestibular system. So sometimes if you have an excess of fluid, that can trigger sensations of dizziness or vertigo. And so reducing the amount of sodium reduces the amount of fluid that's retained in your body, including the inner ear. So that's one way in which a change to your diet can have an impact potentially on your feelings of dizziness. Okay. That's one of people who go to physicians who have dizziness or vertigo symptoms. That's usually the first line of treatment. Try changing your diet to see if it helps, because sometimes it does. And you're welcome. Okay, so as I mentioned at the very beginning, hearing difficulties or hidden hearing loss related to brain injury is really my area of interest. And so this is when you have injuries to the areas of the brain that are responsible for processing speech. So you have these subtle injuries that you can't see on a scan. So you can't have an MRI or a CAT scan and see this injury, but there is an injury to these areas that impacts your ability to process speech. Maybe not in quiet, maybe not right now because you're concentrating and you're alone and it's a quiet environment. But what about when you try and go with your family for a Thanksgiving dinner, or you try and go to a restaurant and there's a lot of people talking? So there's a lot of noise in the background. A lot of restaurants have reverberation where sounds bounce all over the place. There's people talking. If you're seated next to the kitchen, you can hear the dishes clanking. And so those sorts of situations are very acoustically challenging and extra difficult if you have this type of injury or these processing problems. Dr. Whitelaw will refer to these as an auditory processing disorder. The other thing that can happen is you can concentrate really hard in these areas and you're doing all that you can, attending to the person you're talking to, and you're understanding them, but it's really hard. And we call that effortful listening, so that you have to increase your effort in these challenging tasks. And it's hard and you experience slower processing. So sometimes remembering what people said is difficult because so much of your effort is just understanding what they said. This is something that we look at because it results, the testing I might do, you might do really well on the tests I have you do, but you're spent, you're stressed, you have a lot of fatigue. And that in and of itself is problematic. It can be very debilitating. And so, my research efforts are trying to find ways of testing for this, but also for treating this as well. So, again, what's the impact and why is this an important area that I think is an important area for study? Well, people who experience hearing difficulties or hidden hearing loss experience reductions in quality of life. They have poor psychosocial functioning, so it may lead to social withdrawal. And then that results in higher rates of depression or emotional distress. These are individuals who will self-refer for hearing or medical evaluations. And so their perceived symptoms of their communication difficulties really warrant seeking help. And so for me, it's if you experience anything like this, it's getting you to the right clinician. And then what can happen is that these are individuals where there's no measurable hearing loss in our traditional testing. And sometimes what can happen, and again, I feel just sometimes sick to my stomach when this happens, is people are told, well, you have normal hearing, and so there's nothing we can do for you. But that's just simply not true. If we listen to your symptoms, if we do further specialized hearing testing, like we do speech and noise testing here in the speech and hearing department, we can tap into these difficulties that you're noticing. So, I have lots of unfortunate stories of individuals who have hearing difficulties or an auditory processing disorder that have been seen by multiple audiologists and told they have normal hearing. So I guess my message is, if this is something that you've experienced, don't give up, come and see us. So, I wouldn't be a researcher if I didn't give you a little statistics to share with you how common this is. So if we look at the literature, if we look at the research, it tells us that auditory processing deficits or hearing difficulties occur in 16% of children who have a history of traumatic brain injury. It's pretty common in athletes who have a history of concussive head injury. And this third bullet, 58% of adults 7 to 11 years post-injury. So that research tells me that these symptoms can linger over time. And then if you look to the veterans that have experienced blast exposure, and we have a lot of veterans from that served in the 1990s during the Iraq war who were exposed to blast or blast exposed. They may have completely normal hearing as we would define it, but really experience listening difficulties, especially in noisy environments. So this is fairly common and something that I think is worthy of study. So what I wanted to do, so pause, how we doing? Everybody doing okay? All right. What I wanted to share with you is some clinical data so that you can see how this woman ended up in our care and how we were able to manage and treat her hearing difficulty or her auditory processing deficits. So I'm going to share with you some clinical data. This is a woman who was in a motor vehicle accident. She and her husband were stopped and they were rear-ended from behind, someone coming at 55 miles an hour who didn't stop. She didn't have any loss of consciousness or alteration of consciousness, so the LOC or AOC. She was transported to the hospital. Her brain and spine CT were completely normal. And this is, I think, one of those things that you may have experienced, that sometimes a lot of the tests that we do don't show the damage or don't link up to maybe the symptoms that we're experiencing. Now, she had a lot of symptoms from this injury. So she had auditory symptoms. She was sensitive to loud sounds. She had tinnitus, and she had difficulty understanding speech and noise. But one of the things I wanted to share with you is that that wasn't her only concern. She had other symptoms. She had memory issues, memory difficulties, loss of concentration. She had light sensitivity issues, so her vision was affected. She experienced dizziness and balance issues. She had physical symptoms with experiencing headaches. And she also had some emotional symptoms where she experienced anxiety related to driving. It took her a long time to be able to drive again. So obviously we concentrated on her auditory symptoms when she got to us. So she reported that because of these hearing difficulties, she couldn't attend her church or family events. And her husband is a pastor, so that was a very big deal. She had a lot of difficulty hearing in a restaurant setting, difficulty in groups due to, for her, sounds were too loud. It's that sound sensitivity. And then this emotional component to these symptoms where she stated she had been robbed of her life. But when we do our standard hearing test on her, the standard test that you would get in any clinic, all of our standard test results for her were completely normal. And so I have a little head scratcher here because this is where this can get frustrating, not only for the clinician, but especially for the patient. You don't want to have all these symptoms and then told your test results are normal. So what do? We keep working as clinicians, and we do specialized tests to investigate these symptoms further. So when we did these specialized tests with this woman, she did show she had very poor performance for speech and noise, especially if we withheld contextual cues. So if I give you a speech understanding test, I can make it easier by giving you contextual cues, or I can make it harder without context because we use context a lot. If I present competing speech, a word to one ear and a different word to the other, that was a very difficult task for her. And then if we really stress the system with temporal processing, so asking her to identify short bursts of sound, how short of a sound could she identify? She had a very difficult time with that. So now if we do these specialized tests, our test results match her perception. So we validated her perceptual complaints, which I think is really important. So what did we do for her? We enrolled her in a hearing aid trial where we fit her with mild gain amplification, very, very mild, not a lot. Hearing aids are incredibly sophisticated now, and we can set them so they just provide just a little bit of help. And she got to the point where she was using those hearing aids, and she still does, 12 to 14 hours a day. Now, it didn't start off that way. I will say that with any treatment like this, there is an adjustment process, right? But she did report substantial improvement when she was listening to noise. The hearing aids made it much easier for her to follow conversations. She found loud sounds tolerable. And that's one of the things, the sophisticated hearing aid technology we have now, we can actually reduce the volume of loud sounds. So, if a loud sound is bothersome, the hearing aid actually makes it a little softer. By 4 weeks of wearing the hearing aids, she was back to attending meetings, and that was a big thing for her. The hearing aids allowed her to participate in those activities. And one of the things that just fascinates me is, as a clinician and as a researcher, is that she has, by our definition, normal hearing. And yet she describes herself as deaf and background noise, which tells you, remember that one of those first images I showed you, the 2 ears connected to the brain? The normal hearing is about what's happening at the outer part of the ear. Her experience is happening at the level of the brain, right? So we have to test all of that. Okay. So now I'm at the very last part of my talk, just to give you a little idea of what I'm working on. And, we'll see how this goes. Okay, so what I'm working on is bringing in people with a history of traumatic brain injury who have hearing complaints and who don't have hearing complaints. So the idea is that I want to use tests that use both ears together. Okay, so tests that force the auditory system to process sound from both ears. And we call that binaural auditory processing. So that's the focus of the testing that I do in my lab. This is just to show you the 3 different groups that we're recruiting. We have a control group. These are adults who don't have any history of traumatic brain injury. We have a group that does have a history of traumatic brain injury, but they don't report any hearing difficulty. And then finally, we have our 3rd group, and this is the group that is the ones that do perceive hearing difficulty. And so we use questionnaires that all our participants complete about their listening ability, about their hearing ability, and that allows us to identify whether or not a patient or participant has these perceived hearing difficulties. And this, again, this is some data from this ongoing study. And essentially what I want you to see here is the red bars and how much higher the red bars on these graphs are relative to the blue and the gray. And what that means, these are 2 different questionnaires that I use in my studies, the Hearing Handicap Inventory for Adults and the Adult Auditory Performance Scale. And what this is showing me is that this group definitely has more self-perceived hearing difficulty. And I think, Kadar, how am I doing on time?
Since we've been taking questions halfway through
Okay.
continuously, I think we're okay.
All right.
And wrap up just a little after 7:30 though.
Okay. So I have a few slides. I have a summary slide here, and then there's one other slide I want to show you that I think really speaks to some interesting findings. So preliminarily, what I'm finding is that adults who have these hearing difficulties do much poorer when they're trying to understand speech in a background of noise. If I present competing words, that cognitive load of trying to perceive one word that's presented simultaneously with another, it's very stressful. That performance is poorer in this group. And then if I do a task where we do tone detection in noise, and we adjust the phase or the timing of those signals, that performance is poorer as well. So not only is the perception of hearing difficulty something that these individuals have, but the testing is showing that difficulty as well. So I'm going to fast forward through some slides and get to this final data slide. The other thing that we're measuring is perceived effort on these different tasks. And again, what I want you to pay attention to, there's 4 different tasks, but just pay attention to those red bars and the fact that they're higher than the other bars. So the blue and the gray are control groups. The red are those adults who have hearing or auditory processing deficits. They are experiencing significantly more effort, or they perceive more effort at doing these tasks. And I think I see something in the chat. Was hearing loss a result of the TBI, or did some have it before? So the auditory processing problems they're experiencing, or the hearing difficulties, is the result of the brain injury. They don't have measurable hearing loss at all. And that is something when we recruit individuals into the study, we test their hearing, the traditional standard hearing test, and these folks have normal on those tests. And then we put them through this auditory processing test battery. So good question, thank you. So again, the message here is that the effort perceived is significantly greater. And this is something that is been reported in the literature, and I'm seeing it with my study as well. Okay, so just to conclude, hopefully I've given you a little bit of information about the auditory system and the impact that a head injury can have on the auditory system. And essentially, it can be one or all of those things, or none. That's one of the things that I'm learning as a clinician and researcher, is that everybody's experience is different. Adults with a history of traumatic brain injury and who have hearing difficulty experience significantly greater listening effort, and that can lead to greater fatigue when listening in these environments. And again, not everybody experiences this, but for those that do, there are effective treatments available, which I think is a really important message for you to hear. And here is my contact information. And I also put a link to our clinic should you be interested in an evaluation or more information.
Awesome. Thank you so much, Christina.
Sure.
This is really helpful. I mean, a lot of stuff that I didn't know, and I'm still taking some of the trivia away as well. Stuff. So I know we've done some questions along the way, but I'd like to just keep a couple more minutes in case you have some. While you're thinking of those questions, which again, you can ask in the chat, or you can ask out loud, or you can send to me and I can ask them out. Any of that works. I just really quickly wanted to introduce our new student rep, Kavya, who is going to be helping to create content for us and help schedule things like the student presentations, but also the interviews. So Kavya, do you want to jump on and just kind of say a little bit about yourself and what you're doing?
Yeah, so hi, my name is Kavya. I'm a 3rd year at Ohio State and my major is neuroscience. This is my 3rd year in Brain. So I actually joined Brain because of NeuroNights. I went to the in-person NeuroNights and I met Ryan and Perry, and I really liked it. And then it went online and I was like, oh, well, I should still be a part of it. You've probably seen me a little bit over the summer. I worked odd hours, so I really wasn't here all that much over the summer, but my main priority is you guys, because I did go to that one meeting where Karen and Angelique both talked about the science behind all these like therapies and all these techniques that these clinicians are talking about. And so we wanted to bring that to you guys because we're the ones taking the classes. So we want to break it down for you guys so you can understand more about what these research are talking about. And then also you can get to learn more about your fellow TBI survivors. And it's twofold because then we can, I don't know if you guys knew, the Ohio Senate recently passed a grant for TBI survivors, I think. I don't know what the exact grant was, but they did that because they had access. They know more about TBIs. Like it's a different world when I can just say TBI, but when you see Ryan's story, which we'll actually share in November, it's different because it very much is a silent injury. So that's why we want to do these survivor stories so that more people can learn about it and the issues that you guys face. So yeah, that's really what I'm here for, is to be the representative between Brain and NeuroNights. And I think the president of Brain, Jenna McCloskey, she was here earlier, but I think she just left. But we're both going to be working together on NeuroNights.
Very good. So what Kavya was pointing out is Ohio Brains is a piece of legislation that we've been trying to get passed for a few years. Thanks to some really good advocacy efforts, as well as, again, as Kavya said, sort of the stories that we have, some of the data that we have on brain injury survivors and their journeys. We were able to get a 400% increase in the state funding for brain injury services across the state.
Nice.
This is really exciting. It's not all the money that we wanted. And frankly, it's not even close to enough.
Hey, Kadar, if you can get money out of the Ohio legislature, you are that's a win.
This is what I'm saying. It's hard to get that. So, I'm very, very excited for this. John Corrigan, who is really the champion of getting this done. He's like the TBI guy here at Ohio State. He's going to be doing some presentations for us later in the year. And I really hope you get a chance to talk with him about some of the efforts that he's been working on. But these stories matter. And we've been told repeatedly that these are the things that are going to push the needle. It's not going to be the data alone. It's going to be the stories. And so if you want to be a participant sort of in that pantheon of things, or just to share your story because it's helpful for you.
Yeah, can I chime in and just say that that's absolutely so important. I deal with advocating for hearing legislation, and those personal stories are so impactful. You can present all the data to the legislatures and legislators, but the personal stories are just so impactful. We're trying to pass legislation to mandate hearing aids for children to be covered by insurance companies, because can you believe that they won't? I mean, why would you deny a child a hearing aid? Who needs it? Come on. But so those kids that come and give their personal stories are so just amazing. So I encourage you to do that. Yeah.
I'm sure that moves the needle. So, so we won't push this at you too much. We do want to make sure that that there's a space for us to do this. And so when you receive an email about this, you'll at least have some idea of what we're talking about. And we can answer more questions at that point in the process too.
So there were a couple of questions, Kadar, in the chat. So Michelle asked, when did the hearing aids that lower loud sounds become available? That technology's been around for quite a while, Michelle. But one of the things that current technology does is it includes noise reduction algorithms so that it really improves comfort while listening. But certainly we can make those hearing aids ensure that they don't take a really loud sound and make it louder, right? We can reduce that for you, which is really,
My hearing aid doesn't tend to reduce loud noises. I can bump it down a couple of notches, but hey, that's why I don't wear it.
Well, sometimes loud sounds are just loud, even if the hearing aid isn't amplifying it, right?
Right.
But you can talk to your audiologist and maybe they can make an adjustment for you.
True. Thank you.
You're welcome. Angelique asked, how do you get referred to your clinic for testing? Angelique, great question. I provided the link there that'll get you to our website, but we are underwritten by the university, so there's no referral process necessary. You can self-refer for an evaluation. You just have to call the clinic and get scheduled. We don't even charge for our services because we're an educational clinic. So we have a hearing aid clinic that we do charge for. Obviously, we charge for our hearing aids. The community would not be happy with us if we didn't do that. But if you want to come see us, please do. There's no referral necessary.
Very good. Karen had a question about veterans. Do you want to ask that out loud?
Yeah, I'm curious. You said you've worked a lot with some veterans that have had TBIs from blasts and things, and I'm just wondering if you've seen any veterans that had blasts with these ear issues, but like they didn't get hit in the head.
Oh yeah, for sure. Yes, that's a great question. And absolutely, that's that's actually, when we say blast exposed veterans, there's no physical trauma or physical injury. It's the actual acoustic blast wave that hits them that causes injury. And that causes the brain to slosh in the head and go back and forth because that blast is so strong. So it's actually, they're because they're wearing body armor, they're, the physical penetrating wounds aren't as common anymore with our veterans or our military personnel in these situations. It's more so that acoustic blast wave that causes that damage.
Okay, I have your email, so I have lots of questions.
Great. I look forward to hearing from you.
Very good. I have two questions. Let me see if I can even get through both of those. So the first one is, I just, when you put up the hearing sort of diagram, right? All the different parts of your body that process or play a role in your ability to hear, much less to, do it well. It surprises me, do we know this subject really well, right? We don't know the brain all that well, right? There's so much that is sort of undiscovered country. Do you feel like that's the same with hearing, or is it pretty well characterized?
I will certainly those outer parts. So the outer part of the ear, we know really well. And in fact, the outer ear, the middle ear, inner ear, a lot of temporal bone studies were done in the 1900s. So post-mortem, people would, some people, donate their bodies to science. And so you can harvest that section of the auditory system. So we know that very well. Also, animal models are very, the mouse model and the cat model are very similar to human auditory systems. So we know it from that perspective as well. But you're absolutely right, Kedar, that when it comes to the central auditory nervous system and in the brain, we have more general ideas of these things. We know where sound is processed, and we're learning much more through techniques like functional MRI, imaging techniques. We learn more from that, where exactly, but how is a different story.
Okay. Yeah. This is just it. Sometimes you'll get to that answer of like, this is as much as we know. And the rest is sort of, an open-ended question of, how can you manage a condition?
Right.
It's interesting to know where that, where the line is of
right.
what we know and what we don't know. Okay. So the second question is kind of going back to what you showed at the very end, right? You had those 4 figures, and what you were showing was, there's this frustration, there's this effort required amongst at least TBI survivors who have had, these hearing difficulties. And something that we've learned in another space is, when you have hearing loss, your likelihood of developing dementia or, these cognitive, challenges, cognitive decline over time, can be, much more common or much more likely. And so just thinking about that effort and stress and the outcomes that you might see for someone who has had a brain injury, who hearing difficulties, what should they be on the lookout for in terms of aging or decline?
Yeah, that is a great question. So far, okay, so let me address the first part, that there is this relationship or an association between hearing loss and cognitive decline, and that individuals who do have hearing loss are more likely to develop dementia over time. It's absolutely true. It's not a direct causal relationship. So hearing loss does not cause cognitive decline, but there's probably a common cause, right? Is the way researchers are talking about that now. The data I have so far, the study so far, is in individuals between 18 and 60 years of age. And so in auditory research, we think of aging not only as, in one sense, as a continuum, but we treat aging population as individuals over the age of 60. And I think in terms of cognitive decline, they talk about it, 60 and upwards as well, right? Although that's completely arbitrary definition. But one of the areas that I want to move into is looking at age-related changes in auditory processing and hearing difficulties in adults who've had traumatic brain injury, because at least in terms of the auditory or hearing component, we don't know. But I did read something just today that suggested that a traumatic brain injury in the past does not necessarily indicate that you'll be more likely to have cognitive decline. Is that a fair statement? I was doing a literature search on this earlier.
My understanding of it would be there are many more factors, right? It's a multifactorial thing. Just because you had one doesn't mean that you're going to have any of these after effects. It may be in the context of stress, maybe in the context of some other life effect. Then those things might go together a little bit more so, but it's really that multifactorial.
Yeah. So what to be on the lookout for? That's a great question. Are you remembering what you heard? Right. So sometimes the effort to just hear what somebody says means that your cognitive capacity is full, and you don't have the cognitive capacity to work that into your memory to remember, right? So you can hear what somebody said, but do you remember it? That's one of those signs, right? I don't know.
No, that helps. Just trying to kind of understand, what should you be on the lookout for? And so, again, if you have concerns or if you have maybe a potential for a symptom of these hearing difficulties, we would want to start with clinics like yours.
Right. Yes. Yeah. And we can get you over to the right neuropsychologist as well. Michelle, you have a question?
Right. But we already have, short-term memory loss. So, that would be extremely hard to determine as you age, because it's already there. What I do, I find if I repeat what somebody says to me, and I tell them, I'm going to repeat this so I can try to remember better, that does help me remember. And I'm 66.
Mm-hmm. Yeah, that's a great point. Great point.
Yeah.
I appreciate that.
I wouldn't necessarily look for that.
Okay.
Because, people already have it, but just tell
people
them.
already have it.
Yeah. Just tell them we acknowledge that you already have that, but has it gotten worse?
Excellent point.
Yeah.
Excellent.
Thanks.
Thank you.
All right, folks. Are there any other questions out there? I don't want to cut anyone off, but unless we have another one in the banks. Oh, no, okay. All right. Well, then I guess we'll for the night. So first off, thank you to Dr. Christina Roup.
My pleasure. Thank you, everybody.
It was a fantastic presentation.
Thank you.
If you have questions, she's got her contact information up there. And then again, stick around for next week where we have Dr. Roop's collaborator, another one of our faculty members at Ohio State, Gail Whitelaw, who is going to come in and talk to us a little bit more about specific issues in TBI related to hearing, balance even, and some other auditory problems. So a really good couple sessions here. So until next week, have a good rest of the week. Be well, and we'll see you on Wednesday next week. Bye, everybody.
Bye.
Thanks, everybody. Thanks, Kadar.
Thank you.
You're welcome.
Thank you.